Great, thanks very much. Welcome everyone. We're going to be talking about TB and HIV service integration within a South African primary healthcare setting. This is the picture that most people kind of associate with Cape Town when they go there. But this is Khayelitsha. Khayelitsha is a very large peri-urban township, about 40 kilometres from Cape Town. Very high rates of HIV, antenatal prevalence of about 30%, and very high rates of TB, 1,600 per 100,000 people per year. That's approximately 1.6 of the population that gets TB in that community every single year. MSF returned to South Africa in 1999 to attend to those living with HIV and AIDS and provided antiretroviral treatment since 2001, which has since been taken over by the Ministry of Health, and they now lead distribution of that. Throughout, there's been strong clinical governance from the Khayelitsha City Health Department that's really helped in the integration process. A lot of you probably know this already, but TB and HIV, you get TB when people cough and you get it into the lungs, and initially your body's defenses control it for a while. However, over months or years, that then weakens and the disease explodes and goes from latent TB into active TB, which is down here. Now, the risk is very different if you're HIV negative or HIV positive. HIV negative, you've got an annual risk of about 0.2% of getting active disease, but when you're positive, that goes up to about 8 to 10%, so greatly increased risk. Globally, there's about 9 million people infected each year. Less than a quarter of those are HIV, and a staggering 1.8 million die each year, and more than a quarter of those are HIV positive. If you're positive, you're 20 times more likely to develop TB in high prevalence HIV settings, and approximately over 60% of patients in Southern Africa with TB are co-infected with HIV. It's called a cursed duet because you're 4 times more likely to die within 1 year of diagnosis if you're HIV positive. So what do we mean by service integration? Well, we mean a one-stop shop, which is being implemented since 2008 in Khayelitsha. It's the provision of TB and HIV services in the same structure, by the same staff, at the same time, and with integrated patient files. This is the example I use. It's all under one roof, 2 diseases, 1 patient, 1 folder, 1 appointment, everything at the same time. You've got an integrated nurse who deals with all HIV and TB case management, and then an integrated doctor who deals with complicated cases and starts ART. You then have 1 HIV testing counsellor, 1 treatment counsellor, and 2 integrated data capturers. There are other modes that people have talked about. They're largely cooperative modes where TB services or HIV services refer to each other or test and refer to each other, but that's not the model that we're talking about here. We're talking about full integration, which we believe is the best way forward, everything done at the same time in the same single facility. So why would you integrate TB and HIV services? Well, there are many proposed service advantages: decreased waste, decreased replication, decreased reporting, and also you increase your provider skills. There are many proposed clinical advantages: earlier ART initiation, decreased drug toxicities as doctors are aware of the interacting HIV and TB medicines, and for patients, more time and more money saved. But there are several identified areas of concern. One is that you might overburden fragile TB services when you ask them to provide HIV care. There's also the concern of nosocomial TB transmission, so transmission of TB within healthcare facilities. And there's a stigma aspect that by bringing HIV care into TB services, you may well cause additional stigma for patients. But really, there's quite a positive formal comparative analysis, which is why we did 3 retrospective folder reviews and 1 set of patient and provider interviews. Ethics were granted by University of Cape Town City Health, and the Western Cape Government. So the first review was time to ART initiation. This was in a fully integrated clinic, and it was a retrospective observational study of 158 ART-eligible TB patients, and we compared 6 months before and 6 months after integration, the hypothesis being that integration may reduce time to ART initiation. Baseline demographics were the same apart from TB type, and it was noticed that there was increased extrapulmonary TB, so TB outside the lungs post-integration, and that's TB that's quite commonly associated with HIV, so we're picking up more HIV-related disease after integration. What did we find? Well, this is the post-integration, and this is the pre-integration. So people start quicker, and more people start post-integration. The median time decreased from 147 days to 75 days of ART initiation, so nearly a halving of time. And post-integration patients were 1.5 times more likely to start ART within 6 months with a hazard ratio of 1.6. And integration may also target sicker patients or facilitate access. Afterwards, there were more disseminated TB, so TB everywhere in the body, and people with lower CD4 counts starting antiretroviral treatment. So may help get sicker patients onto treatment faster. We then looked at TB outcomes in an integrated clinic versus a not integrated clinic. Again, retrospective observational study, about 1,000 patients in the integrated and 500 in the non-integrated just due to facility size. And we looked 12 months pre and post-integration in the integration clinic. The hypothesis here is that addition of HIV care may overburden fragile TB services and adversely affect TB outcomes. Again, baseline demographics were quite similar, except there was noticed to be increased smear-negative pulmonary TB and extrapulmonary TB post-integration. Again, we're picking up more HIV-related disease, treating more HIV-related TB afterwards. What did we find? Well, if we look at people with negative outcomes, which are deaths, loss to follow-up, and treatment failures, they're roughly the same. So in the integrated clinic, you go from 20.5 to 19.5, and in the non-integrated clinic, if anything slightly worse, 20 to 20.3. But if we look at the risk ratios for before and after having a negative outcome, in both clinics, they're about the same. So really what we're saying is that in this setting, there was no evidence of worsening TB outcomes post-integration. This is just to show that since 2008 within Kalycha, if we look at smear-negative disease, we're picking up a lot more, and we're picking up more extrapulmonary disease. So there's a suggestion that post-integration, we're picking up overall, not just in the clinics we looked at, a lot more HIV-related disease. We then looked at some notes. So we in the fully integrated clinic, we aimed to look at 100 sets of notes, pre and post. We found from our sampling frame 94 and 92 of those. And the hypothesis is that we would find improved HIV care recorded within the notes after integrating services. Some of the findings were detailed HIV history went dramatically up, so much better documentation of the HIV past and potential problems that people might have, and there were much more questioning for drug side effects, for opportunistic infections, for sexually transmitted diseases, in addition, post-integration. And in keeping with dual treatment, the increased number of clinical visits that people with HIV went up quite dramatically from 4 to 7 per year. But the big finding was that there really were fewer problems with HIV care linkage. So before, we saw a lot of difficulties with linkage into HIV care. Now, what do we mean by that? Here are just a couple of examples. Complex ill patients, patients with immune reconstitution, patients with multiple side effects, having to be referred back and forth between the TB and HIV side, often long delays, getting deteriorating outcomes in the meantime. Other things are patients on nevarapine, which is an HIV drug that you need to switch when you start TB treatment due to drug interactions, having long delays or maybe even uncertainty if they ever changed onto the more appropriate efavirenz drug. We've got now just a little clinical vignette. And this is a new patient who was negative sputums to start on TB treatment, January. 2 weeks later, the nurse gave a letter to the ARV clinic. So quite a very prompt referral to an ARV service. This is pre-integration. But then we get this, patient defaulted for over a month, claims he thought he'd been discharged, medical officer to see, and then the doctor reviews the patient, and his patient has had a misunderstanding, thought he was being transferred to another clinic for ARVs as he thought he'd completed TB treatment. It's really easy to see how that type of misunderstanding in a really busy clinical environment could happen, and we find time and time again in the notes evidence of this type of problem when people were being referred between two clinics. Finally, we did a set of interviews. It was in a fully integrated clinic versus a partially integrated clinic versus a not integrated clinic. We chose a representative selection of patients. Those are 42 people with either HIV, TB, or both. And then we also interviewed staff and key community leaders and academics. The hypothesis here was that your opinion of integration might change by your HIV or TB status or by the clinic that you attended. All but 2 of the patients favoured integration. The 2 that didn't, one was HIV positive and was worried about infection concerns, and one was pending an HIV test, and there was the stigma of HIV that she was quite worried about, very likely to be positive in her case. There were also 4 that really liked the idea of being treated by the same staff in the same clinic, but were unsure about one waiting room, and one thought they were different diseases, so maybe different doctors would be better. There was widespread buy-in from staff, if it's well-resourced, of the benefits to their satisfaction and improved skills, and they did notice that they were getting better clinical management of the co-infected patients. And even though there were some initial teething difficulties with integration of services, these had largely been overcome a year later. These are just some sample patient comments. So people just with TB, going to an ARV clinic doesn't bother me at all. TB is a friend of HIV, and it's very good to get treated together. Another one saying, and this is one of the concerns, is that people with TB are going to be stigmatized by HIV. I don't care if people may point and say, I have HIV, as I know I don't. People just with HIV saying, it's okay if I do dual clinic as I can protect myself with a mask, and it's better because some people can't afford to go to many places, so it's a good idea. And then people with both, it's good if together in one big waiting room as no one knows why you're there. It might be HIV, it might be TB. And also it was very difficult to get to the other clinics before as I needed more transport money. Now it's much easier. So these were the type of comments we got, just very broadly supportive of the notion of service integration. Ways that you can overcome the problems of either nosocomial transmission or stigma. This is one of the waiting rooms. Big, airy, well ventilated, and it's got ceiling extractors to facilitate air exchange and to really decrease any potential for TB transmission. And also everyone in the clinics in Kailicha wears a mask, no matter what you come from. And it's both as a means of infection control. It's also to destigmatize TB and or HIV because no one knows why you're there. Everyone is wearing a mask. So, key points. Well, one-stop shop integration resulted in a significant reduction in time to ART initiation. TB outcomes, despite concerns, were not negatively impacted. Integration is widely acceptable to patients and staff alike, as well as the academics and the key community members. Clinical skills were improved, as was record keeping, particularly for HIV-related illness. And overall integrated services should lead to better outcomes and quality of care and are urgently needed. There are a few caveats to this about the generalizability and representativeness of the results. We only looked at several clinics, and obviously we had a preset sample size from that. There already, through good clinical governance, have been well-established HIV programs in Kailicha, and that may have pre-sensitized staff and actually limited any improvements that we've seen, particularly in TB outcomes, because they were already used to dealing with HIV-related TB. May not be representative of the wider picture of service integration given different levels of program funding and structure across Southern Africa, and indeed the degree of HIV stigma in South Africa, particularly in Kailicha, from all the work that's gone on there, particularly with TAC, may not be generalizable to the rest of Southern Africa. Just like to acknowledge all these people, but in particular all of the clinic staff and indeed particularly all the patients that contributed. Thanks for listening, and I welcome any questions.